and then it just do the gene transfer. Or sometimes we can't do that. Then what we have to do is that we have to collect your cells, right? We collect your T cells, immune cells, or we collect your hematopoietic stem cells, cells daripada marrow, dari sum tulang tu, we collect them. Sel-sel ini kita kirim kepada satu makmal, dalam makmal, we do the gene transfer, right? Kita add the gene ke dalam sel itu, habis kita pulangkan sel itu kepada say rumah sakit Dr. Jamil dan Dr. Amira ke atau Dr. Amy ke akan infuse the cells. So, rawatannya atau gene transfer ini dibuat secara ex vivo, outside the human body. Or we do it directly in vivo inside the body to help prevent or treat disease. So, in the definition ni, ya, the definition. A treatment that adds a new gene, replaces or repairs a mutated gene, either in vivo or ex vivo, to help prevent or treat diseases. That's gene therapy for you. A classic example of a gene therapy is the COVID-19 vaccine. I had 4 doses of mRNA vaccine. How many of you had mRNA vaccine? Ada. How many of you had the adenoviral vaccine? Ada. Mesti ada. Huh? Kebanyakan of you had what vaccine? The attenuated virus vaccine from Sinovac. Itu paling popular dekat sini ya. Yeah, COVID vaccine ya. mRNA. Many people had the AZAC atau the CanSino punya vaccine, which is the adenovirus, right? That is a gene therapy. Do you know that? I mean, they call it a vaccine, but it's actually not a vaccine. It's a gene therapy. What happened is that here, do you have a laser? You got a laser? No laser, huh? Not the laser. No, no, go back. So the vector-based vaccine for COVID-19, right? You see that? AZAC, CanSino. It uses a virus called adenovirus. Virus in it carry a gene. The gene is the gene for the spike protein of the SARS-CoV-2 virus. So what we are getting, the vaccine is we're getting a virus that carry a gene. Selepas dicucuk ke dalam kita, the virus infect a cell, or typically the dendritic cell, right? The DC. And then the virus transfers the gene into the cell. And then the cell uses our cell machinery to produce the protein. If I transfer the gene to you, your cell can now produce a protein that the gene encodes for. In this case, the spike protein or the SARS-CoV-2 virus. The cells now expresses the spike protein. The body recognizes that this is foreign and therefore induce an immune response. That's immunization lah. Tapi caranya menimbulkan immune response itu adalah melalui gene therapy, melalui gene transfer by a virus, in this case an adenovirus. Itu sepatutnya, that is in fact a form of gene therapy. No different from what we are doing. Next. Now, this is a very hot subject now because people are getting a lot of Nobel Prizes for doing something, for doing some new discovery in gene therapy. I'm sure you guys know this too. Dr. Carpentier and Dr. Donat. They discovered the CRISPR, right? The CRISPR-Cas9 enzymes. That's a tool now that we use to do gene editing. There is now a gene editing therapy now. I'll show you later on. Next. The other 2 persons, of course, is Dr. Kariko and Dr. Weissman, the person who did most of the basic research on mRNA. mRNA is a very popular vehicle now to do gene transfer, which in fact, exactly what happened with the COVID-19 vaccine again. The fact that the COVID-19 vaccine could be developed so quickly, and the first one was the mRNA vaccine, was because all we had to do now is to know the sequence, the mRNA sequence of the spike protein, transfer that into mRNA, right? Wrap mRNA around in a lipo nanoparticle, and that's a vaccine. because the lipo nanoparticle will now transfer the mRNA into your cells. The moment the mRNA is in your cells, it will be now expressed as a spike protein and therefore cause an immunization. That's how it works. The same technology, exactly the same technology, can now be used to transfer other gene for purpose of treating other diseases besides COVID-19. Yeah? I'll tell you more about that. Next, please. A normal copy of a gene, there and below, you're cured. I give you a copy of S1 gene, that's it. Thalassemia. You're lacking in the beta globin gene. Yeah. Now I just have to transfer a normal copy of a beta globin gene and replace that in your cells. You're cured. Easy, right? Especially for monogenic diseases. Diseases due to a single gene, we call them monogenic diseases like SMA, like thalassemia, like Fabry disease, long list of diseases, right? That's the easiest. And that's the one that you probably will think of naturally. The second way you can use a gene therapy is as a biofactory. Let's say you have a disease. You need to have a certain protein or antibody injected into you every week. One way to overcome having to inject you every week is what? Is to give you a copy of the gene in some cells and then ask your cells to produce a protein every day. That's clever, right? So this is not genetic anymore, right? There's no genetic disease here. We are merely using gene therapy as a technique to cause your cells to produce a protein, a therapeutic protein that you need for your disease on a day-to-day basis. We call it a biofactory, using your cells as a biofactory and using gene therapy to transfer the gene into the cells. The third way, and that's actually quite most interesting one, which in fact we do a lot more than for gene replacement, is to use the gene therapy as a form of immunotherapy. Now that's interesting. You say gene therapy is gene therapy, immunotherapy is immunotherapy. Apa berkaitannya? What's the connection there? In fact, there's a huge connection there. I will tell you more about the details later on when we come to that section. All right, next please. Okay, so let's start with gene replacement therapy. Gene replacement therapy for monogenic diseases. Number one, of course, SMA. Because it's one of the first, among the first gene therapy ever to be approved for a monogenic disease, right? Long time ago, since 2017 or 19 was already approved. It's an old treatment now. It's no longer even a new treatment anymore, okay? Then you have what? Spinocerebellar ataxia, spinocerebellar ataxia type 3. The first two are for neurology, yeah? Then 3 and 4 are for hematology, right? That's why I work with Dr. Amira. Thalassemia, beta globin gene, and then hemophilia B, factor 9. So you have a mutated copy of the factor 9. Therefore, you have hemophilia B. Now, if I can transfer a normal copy of the factor 9 gene into your liver, you're cured. And in fact, they are cured. Okay. On the last column, there are a name. You notice the name is all very long. So gene therapy have very long names, all right? And then it shows that they already approved. These are not new anymore. They already approved. People have been using them now, except that we don't use them in Malaysia, you don't use them in Indonesia, okay? 5, 6, 7. 5 is for an eye disease. Labor congenital amaurosis due to a mutated RPE65 gene. Doesn't matter what the gene does, you have that gene, you're blind. You became blind from that particular eye disease. So it's a form of inherited retinal disease, right? There's an approved gene therapy for that now. The latest that just happened about 2 months ago that came out of the news, autophyllin gene. Autophyllin is a protein unit for the cilia in your inner ear to function normally. You don't have that protein, your cilia died, you have hearing loss. You have sensory neural hearing loss. There's a gene therapy for that. Maybe have seen the video. It's just amazing. Just inject that into the ear, and that's it. The baby now can hear. Then there's something called HSCOL7A1 gene. Doesn't matter what it does. You don't have that gene, you have a very nasty disease called recessive dystrophic epidermolysis bullosa. Any dermatologist in it? Tada. You have, yeah, I'm sure you have in the hospital, but not in the audience, right? No. Tada. Not in the audience. Huh? That is a nasty disease, okay? Very, very painful because basically your skin just fell away. You know, bullosa, right? Epidermolysis bullosa, that's nasty. The baby cried all the time because they're in pain all the time. There's a gene therapy for it now. Just replace the gene. The last two are inborn error of metabolism, you know, inherited metabolic diseases. One of them is Menkes disease due to error in the copper, right? Copper metabolism. And then Fabry disease is one of the glycogen storage disease. So there are a lot more now. A lot more. In fact, there are more than that, but I just put up a few to show you. Next, please. And so the reason I'm here today, the reason I'm here standing here talking to you today is because of this baby. Yeah, we can't see the face. Oh, please. 5 months old, referred by Dr. Amy to me, and hypotonic weakness, but luckily at the time not on ventilator, no feeding tube. She has SMA. She has spinal muscular atrophy type 1. We send the blood away for genetic test. The genetic test result come back, confirm positive. As you know, this kind of baby don't live very long. They go on to live for a few more months. They be into respiratory failure. They cannot feed themselves. They cannot telan. They cannot swallow, and then they died up. This is what we did a few weeks ago. We gave them 1 dose directly intrathecal, just 1 shot. I was hoping to see her well today, but unfortunately she got pneumonia and she's admitted to the hospital with an infection. I hope she will recover from the infection and then grow up to become a normal baby. Yeah, okay. So, but then that's another story. So we have the first baby ever treated, I think. The first baby ever treated for spinal muscular atrophy using a gene therapy in Indonesia, not just in Padang. Believe me, in Indonesia, okay? No. They belum sembuh baik lagi, okay? We better not congratulate ourselves until dia sembuh baik. Yeah, next please. This was a result published way back in 2017, long time ago now, right? The first report that came out of the effectiveness of gene therapy is virtually 100% cure. You treat them young. The younger you treat them, they all cured. 100%. All of them grow up to be normal babies. In countries like Taiwan now, or in US now, every babies who are born, you get a blood test for SMA. They test everybody for SMA. If you have a normal gene, you have SMA detected from newborn screening, they treat you immediately. You don't even have symptoms, nothing. And then you grow up normal. You don't even know that you have SMA. All based on testing, screening tests. I was just talking to Dr. Amy, we put together some kind of screening program. We can't go out there and test every babies out there. That's not possible. But babies coming into this hospital, they are sick, they are hypotonic. And then you go back to the last slide. Go back to the slide before. You see the picture there on the left, on the right? So that's hypotonia, right? You pull the baby up, the head goes back, the head leg. Okay? On the right picture, that's called a horizontal suspension test, right? You suspend them like that, normal baby should have the head up and, So we see babies like that in Dr. Jamil Hospital next time. We send them for SMA testing. Of course, not all of them will be positive. In fact, probably only 5% will be positive. But it's okay. The test is not expensive. So we detect them when they are just hypotonic and treat. They're cured. You wait until they are sick, they're on ventilator, very, very hard. It's hard to treat. Then they die. Okay. So we are hoping to start this program as a research together with clinical research. And we're going to test more babies here so that we can treat them early. The earlier you treat, the better the results. Okay. Next, please. Go back. Go down. Down. Yeah, go down. Yeah. Go down. Okay, the next disease I want to tell you about, another gene therapy I want to tell you about is thalassemia. I'm sure all of you have seen thalassemia, right? It's very common. Very common in Malaysia as well. I think it's very common in Indonesia as well because we're all part of what happened at the bottom. Oh, it's okay, no man. We're all part of the belt, right? We call this the Asian thalassemia belt, right? We are in two belts. Okay, we have the Asian thalassemia belt, which is the beta globin. We also have the HBE belt. So we have double. We have a double dose of gene mutations. Okay, double dose of hemoglobin beta gene mutations in this part of the world. Very unfortunate for us. That's why we have got so many babies with thalassemia. We share that with southern China, Yunnan, Guangxi, Guangdong. The reason I tell you about southern China, you understand later on. All right. They also have some thalassemia, but they don't have HBE. They only see beta thalassemia. Next, please. So that's the mutation, the prevalence, all right? The prevalence of carrier, of gene carrier. What percent of the population carry the gene, okay? For HBE or for beta thalassemia. You look it down there, Indonesia, 1 to 25% carry. Indonesia is a big country, right? So in different parts of the country, they do the epidemiologic study, they find different percentages there. And 3 to 10% beta thalassemia. Look at Malaysia, is it 3 to 10%, 1 to 5%. The champion here in Southeast Asia is Cambodia. 1 in 2 Cambodian carry the gene. Okay? You just simply you simply marry anybody, chances are he's a carrier. Okay, so I mean, in marital screening, right? You try not to, if you have thalassemia carrier, try not to marry another thalassemia carrier, right? But takkanlah, all this jodoh thing, how to go and do testing, yeah. But in Cambodia, no chance. No chance. You sure going to marry another person with thalassemia carrier, okay? Very tough, okay? And look at Guangxi, 5%, right? They don't have hemoglobin E. Yeah. Next, please. And I mean, you see the patient in the ward, in the clinic, you think they are well. You give them transfusion, you give them chelation. Actually, they die quite fast. They don't die like SMA type 1, they die very quickly, but they die still 35 years later. This is Malaysian data. Malaysia, we transfuse them. We give them iron chelation. We do quite well. We do really give them, we try our best to give them the treatment they need. Not 100%, not perfect, yeah. And still, it's 35 years. So they grow up to become adult, 35, and then they die. Half of them. Median survival, 35 years, okay? So it's not a nice thing to be. You're young, you're on transfusion, and then you grow up, that you're probably going to die when you're 30, 40 years old. What kind of life is that? It's better to be cured. Now you can be cured. Next, please. This is the data, again, published again in New England Journal, way back in, quite a long time ago now, many years now. 100% cure rate for HBE beta naught. Okay. So the hybrid disease, the HBE beta hybrid disease, major thalassemia, is 100% cure. Everybody who were treated, no more transfusion for the rest of their life, grew up to be a normal person. That's amazing, huh? Just one thing, just one treatment, one shot. Satu kali rawatan saja. All gene therapy is satu kali, ya. You don't have tiap-tiap bulan ke tiap-tiap minggu datang balik ke rawat lagi ke tidak. Satu kali saja. Sekali kita rawat, habis, cure. That's amazing part of gene therapy. But gene therapy mah kan, aku dah replace kan, aku dah replace gene. Your bad gene with a normal gene. Kita hanya perlu buat sekali sajalah. Apa nak buat berulang-ulang kali nak buat itu? Easy, ya. Next, please. The next one is amazing. I told you, right? Dr. Duna and Carpentier won a Nobel Prize for discovery of CRISPR-Cas9. That's the gene. That's the enzyme used to do gene editing. Gene editing. Probably you haven't heard of it. It's a new thing. New thing in gene therapy. First gene editing therapy approved. We now use gene editing to treat patients. It's not even an experimental thing or scientific research thing. It's a routine clinical thing now, at least in the US. First CRISPR therapies approved. That was quite a landmark for all of us in the field. Huh? Wow, that was fast. Next, please. So let's come back to the thalassemia story. So ini dekat Malaysia. Seluruh Malaysia, satu provinsi, satu state yang paling teruk thalassemia ni adalah Sabah. Ya, berdekatan Kalimantan sana, ya. 1 in 3 Kadazan, ya. One of the ethnic group there. 1 in 3 Kadazan. The carrier, 35% carrier rate. A lot of Kadazan got thalassemia. They have 22% of all thalassemia in Malaysia are in Sabah. So very unfortunate for them. I mean, like Sarawak, you have Dayak and other ethnic groups. They don't carry that much. But for some reason in Kadazan, they have this carrier of a particular gene called Filipino beta knot deletion. So if you even know the specific mutation in the beta globin gene, the Filipino beta knot deletion. Below is Guangxi. Guangxi is a southern province in China. 5%. 5% carrier rate. 5% of the population carry the gene. Okay? The reason we put the two together is because, in Guangxi, more than 10 years ago, since 2010, they started a program. They call it the Guangxi model. Okay? They started a program, and the mission was they're going to eliminate, hapuskan thalassemia di provinsi Guangxi. I mean, you think about it, that's crazy, right? How can you eliminate a disease that affects 5% of the population? Tak mungkin ini. Yeah. And they did it. No more. They got hardly any thalassemia there now. We were very curious in Sabah. We were very curious because we got a problem with thalassemia in Sabah. So how the hell they do it? So we went there. Next, please. So that's us there. Yeah, we were up there. Guangxi Medical University, First Affiliated Hospital in Nanning. We were all there. The Sabah team. The Sabah team went there. I was there, so I think you can see me there, sitting somewhere. We also went to another hospital. This is Yunnan. You know, in Yunnan, another province in southern China with a lot of thalassemia. So we went there to try to learn from them. What you guys did to eliminate thalassemia. And it's just amazing what they do. Okay. So one of the things what they do, of course, is transplant and gene therapy. They cure everybody lah. Don't come back for transfusion lah. Kita just cure. Habis cerita. No need to treat anymore. Next, please. So we are now offering this treatment now to a lot of Indonesian patients. In Malaysia, we are sending our patient to Guangxi or to Yunnan to treat. Because we have no experience, so we send them dulu lah. And next time we work out something so that we can start doing it in Malaysia, in Sabah, in fact. The same thing is happening now. This was in Medan, the one is in Jakarta, with Dr. Eddie in Jakarta. We are now asking them to look for patients I'm also telling Dr. Amira here, if you have patients who want to consider this, let me know. Gratis. Everything gratis. Okay? It's free. You're going to be cured. Okay? Then we all go and learn. After that, they will agree to do the transfer of technology to us. Mungkin tidak ke Padang lah. Mungkin ke Medan. Padang, I don't know whether it can support the facility kan. Atau di Jakarta kan. At least one place lah. Mungkin dari Jakarta kita boleh kirim rawatan ke Padang, ke Medan ke. So we are beginning to do the same thing now in Indonesia. We are offering this to all the hematologists yang nak bercollaborate. Okay, next please. So there you are, the monogenic disease, spinal muscular atrophy, thalassemia. There's one now for hemophilia B. I'm sure Dr. Amira will have patients with hemophilia B. And even in Malaysia, the factor replacement is very difficult because it's costly. If you want to do it prophylactically, you have to give them intravenous, not just subcutaneous saja, and it's tough. So they still grow up with arthroplasty and Now, one shot. Just one infusion. Setengah jam. Infuse. Habis. You are free from factor replacement for the rest of your life. That's just crazy to me. Right? Yeah. So let me know if you want this. And then Menkes disease. So these are the therapy for which we now currently have as gene therapies, and we are making them available to the patients in Dr. Jamil. Okay, in the Rumah Sakit ni, together with your specialist here, collaboration, and we'll do the clinical research. This very nice lady here is going to submit the protocol to your pengarah here, and hopefully we get the protocol approved, and kita boleh mulakan menjalankan program ini dekat sini. Okay, next please. Now, you heard me tell you a story about using the cells, the human cells, as a biofactory, as a factory to produce protein. To tell you one disease, age-related macular degenerations or diabetic macular edema. Any ophthalmologists here? Other ophthalmologists, huh? So ophthalmologists use this drug called aflibercept. Ini sesuatu sejenis ubat protein. Tiap-tiap bulan, the patient will come and they check. Okay, take a needle, pop into the eye. Okay, intravitreal injection into the eye. Tiap-tiap bulan. Satu kali, $1,000. Okay. Ini ubat ini dari Amerika Syarikat ya, mahal ya. So kebanyakan patient mungkin tak mampu lah. Mungkin dia buat satu kali, dua kali sajalah. Sepatutnya kena buat setiap bulan satu kali. Ya. So now we come along and we do a gene therapy. Kita take the protein, 6 is a virus, a herpes simplex type 1 virus. If I inject that virus into you, it will kill cancer cells. Of course, the virus has to be genetically modified. And we do some other genetic thing to that virus to make it kill cancers. I'll tell you more about it next. So this is for CAR-T, chimeric antigen receptor T cells. All right. This has been around a long, long time now. It's a T cells. We engineered the T cells by inserting some gene, the CAR gene, into the cells. Next, please. And then it will then kill cancer cells. The data was first published a long time ago now. 30 children with leukemia relapsed. They had transplant. They have everything. They relapsed. They're waiting to die. Give them CAR-T, 78% at 6 months in remission. That's just unheard of results. Of course, this is now in the market. It's marketed now in the US. Next, please. We did this. This was one of the first child ever treated with CAR-T way back in the US, in the first clinical trial in the US, way back in 2012. Today, she's still alive. So she's 2024. She's well, she's a young, from a baby now, she's a young lady now. Yeah. Next, please. And we did the same thing. That's Emily Whitehead in the US. So the Emily Whitehead of Indonesia. May I introduce? Next, please. There, that little girl there, see? That little girl there with acute leukemia, lymphoblastic leukemia, was in Damais, Jakarta. And leukemia, treated, induction, and eventually relapse. We went over and we gave her the first CAR-T. First Indonesian child to receive CAR-T. Way back in 2018. She's from Lampung. Sumatra. She is still in remission today. Okay? Still in remission today. Yeah. That's amazing. Yeah. Well, I look so young those days. Well, I'm very old now. Next, please. The man on the left-hand side, Dr. Eddie. That's the pediatric oncologist. Those days are in Damais. He's now in Suci Hospital in Jakarta. Yeah. That is CAR-T. This is another one called oncolytic virus therapy. So, oncolytic virus, OV. Yeah. Genetically engineered attenuated virus, typically HSV, herpes simplex 1 or otherwise adenovirus, selectively infect and lyse tumor, leading to release of tumor antigen, and therefore cause an immune response. In situ vaccination, if you like. Not something we give from outside, something we induce inside you. The transgene leads to expression of cytokine IL-2 interferon as well as anti-PD-1, and therefore leads to engagement of innate as well as adaptive immunity. I don't know if you understand what I say, but these are good things to happen to you when you have cancer. You want this thing to happen to you when you have cancer because all this immune response will help your body get rid of your cancer. Okay? Tampira there, the mirror next, please. And this is TVAC, the first one. The first oncologic virus therapy to be approved way back in 2015 in the US for melanoma, for sarcoma, for breast cancer, for peritoneal cancers. It's just amazing what we can do now using our virus and gene therapy to kill cancer. Next, please. That's me again, this old man. This old man had bladder cancer. The doctor said, sorry, we got to remove your bladder. I mean, you want to keep your bladder, right? I mean, you want to pee, right? You want to be able to pee instead of peeing out from a hole, right? So this woman is undergoing the trial using a TVAC, using a T3011, the next generation TVAC. Hopefully, she'll stay in remission and he gets to keep his bladder. Tak perlu berdekat. Next. We have so many. On the left-hand side there, you see that? That's a salivary gland tumor. You know, salivary gland? In this case, among epitheliaceae, nasty. You don't want to get that cancer. Look at that. We're going to inject that. We're going to inject that with TVAC. At the bottom there, there's something called pseudomyxoma peritonei. You probably haven't heard of that. Some funny cancer you get in the peritoneum, inside here. Okay, we're going to infuse the TVAC inside the abdomen, inside the peritoneum. Treat it. All these patients had everything. They had surgery, they have radiation, they have chemotherapy, they have everything. ever written in the oncology textbook. Okay, and the cancer is still there. On the right hand side, this is a very sad case. Liver embryonal sarcoma. This boy is only 18 years old, 18 tahun saja umur. So again, cannot have surgery. It's not surgically resectable. Had radiation, had chemo, had everything. Of course, they're trying to save his life, right? Because you're only 18 years old. But embryonal sarcoma is a very nasty cancer to have. He's going to die soon. So finally, agreed. He's going to undergo this treatment. I hope we save him. So there are a lot of new things now, okay, that we try to, especially for pediatric, right? For children cancer. We try not to let children die, right? I mean, orang tua like me now, mainlah mati sudahlah kan, ya. Muda lagi janganlah, ya. Next please. Sorry, I don't mean you, I mean myself. Okay, so next please. So now come to the reality thing, the real thing, the real world. Unfortunately, next please. The real world, unfortunately, is like that lah. Okay. So ini SMA gene therapy, ada dua bayi dekat Malaysia telah menerima gene therapy for SMA. Ibu bapa ni bayar sebanyak 9.8 juta ringgit Malaysia. Itu berapa bilion? Berapa bilion rupiah? Aku tak tahu lah. So it's very costly. Perawatan itu memang yang mahal ya. So you are not going to see them being sold in no. Ubat ini memang dah lama dah dijual di dekat Amerika Syarikat. Tapi company syarikat itu pun they don't even register in Indonesia. It's not a registered treatment in Indonesia. Sebab dianggap tak mungkin ada Indonesian mampu membeli ubat ini. Tidak register dekat Malaysia juga. Sehingga until kedua-dua budak ini they go out there, they go to kita bisa, they go to Give Asia, raise a lot of money, okay, to pay, donation, charity. Next, please. The most expensive drug in the world now is what Dr. Rami just asked me to give it to her. Okay, the most expensive gene therapy in the world today is the one for metachromatic leukodystrophy. Okay, $4.25 million. One shot. Just one shot. $4 million. Okay, how to buy? I'll try to get this, I think, hopefully within this year. The first patient with metachromatic leukodystrophy to be treated in Rumah Sakit Dr. Jamil will happen this year. Okay. Next, please. So the reason I show you all this is because we believe ultimately for us to be able to treat patients, we have to do something like that. We have to bring the technology to Indonesia. You cannot just buy it. Okay? It doesn't work. Indonesia is a big country. Yeah, a huge country. We can do the technology here. Next, please. So this is how you do it. I don't want to go into the detail of the process of how we go and do the production. Next. And if you want your people to get access to a treatment, there's only one thing you must do. You must do the manufacturing here. Bukan dekat Padang lah. Okay, Jakarta ke mana ke, I mean. But you got to do it here. Next, please. Centralized versus near patient model. Okay. The near patient model, the localized manufacturing is the only way forward to bring a new therapy, to make a new therapy accessible to the population. Next, please. So this is what we do. We are proposing. We will first come, we treat some patients, we get our clinical research protocol approved, and then we start talking to our people, start lab, do production. Hopefully, one day we can treat everybody. Itu misi ni, okay? That's the mission. Next, please. There you are. That's what we're going to do, right? Thank you very much. Any question?
Yeah, thank you very much, Dr. Lim, for your great lectures. I think we can learn many things from your lessons. Now, I'll invite the audience and also, yeah, I'll change to Indonesian, I guess. Ya, silakan kalau ada pertanyaan dari audiens di Departemen IKA maupun Bapak Ibu yang berada di Zoom meeting secara online, dipersilakan. Ayo, nanya, Dokter Riri. Ya, Dokter Riri. Ya, please, Dokter Riri. Dokter Riri is here from our management. Yeah. Yeah. She is also a
physical medicine and rehabilitation.
yes, physical medicine and rehabilitation consultant. Please, Dr. Riri.
My English not so good, so I will talk in Indonesia. Oke. Terima kasih kuliah yang sangat menarik. Yang ingin saya tanyakan adalah tadi Dr. Lim menyatakan bahwa begitu mereka mendapatkan gene terapi, all cure semuanya. Berarti kita bisa, si anak-anak tadi bisa tumbuh dan berkembang seperti anak-anak yang lain seperti itu. Nah, yang lain. Emang ada berlainan, ada baru ya? No. I mean, like the others, So they can develop like the others. So that's a good news for us because we want after they get the gene therapy, they can develop as the others. Pertanyaannya, sedini mungkin, as soon as possible. You said that we have to give the injection as soon as possible. So how soon? That's the question. Good question. And then the second one, I saw here about the DMD, Duchenne muscular dystrophy. They also have the gene therapy. Can you give the information? Thank you.
Okay. First question first. How soon should we treat? That's a critical question. Huh? So dekat negara maju atau seperti negara Taiwan, semua bayi yang dilahir menjalankan screening. Right? It test gene, ada SMA ke tidak. Kalau ada SMA, masa itu baru dilahir memang tak ada simptom. Nothing. They treat. All the children grow up to be normal. Okay. Kalau you treat like baby Alona, by the time she undergoes treatment about month 5, you will not achieve 100% cure, right? That's physiology. The neurologist can explain to you. So as you grow up, the motor neuron cannot develop because of lacking in SMN1 protein. So the motor neurons start dying off. And as you may know, for neural cells, what are dead are dead. They don't recover. Right? You are born with so many neurons, right? The number of neurons you are born with in your brain and your spinal cord is fixed. What increases as you grow is the connection, right? The neurons are interconnected with each other. But the neurons don't grow. Neurons do not multiply, not like liver cells, right? Liver cells will regenerate, but not neurons. So what the babies have lost, they have lost. But if they are treated at month 4, month 5, still very good chance, in fact, almost certain he will still grow up to be able to walk. We are now doing for some adults. That's the most sad case. So the adults, they have a milder type of SMA, just type 2, type 3. So they're able to walk until they're about age 20, 18, and then they start not being able to walk. They will eventually be in a wheelchair. They'll be wheelchair bound. So we need to treat them now so they don't become wheelchair bound. In other words, all we can do is preserve your motor neuron. We cannot give you new motor neuron. Itu tak mungkin. Physiologically, scientifically, it's not possible to give you new neurons. You don't grow new neurons or new motor neurons. We can only preserve what you have. So therefore, as early as possible. In fact, I can tell you the story, the dua bayi dekat Malaysia yang bayar novartis sebanyak 2 juta lebih dolar Amerika supaya untuk menerima rawatan gene therapy itu kan. Memang makan masa nak raise money. I mean, you go to Kitabisa, you go to Give Asia, tak mungkin satu hari you can raise $2 million. It took them more than a year. Selama lebih daripada 1 tahun, baru they could raise more than $2 million. So by the time they raise the money, their conditions sudah merosot. Banyak merosot dah. And then they undergo the gene therapy. The result is no good. In fact, they were very disappointed. The result is bad because they are treated too late. You have type 1. Type 1 is the most severe form of SMA, and you don't treat them early, they are bad. So yes, treat as early as possible. And that's for SMA. The same actually apply for thalassemia, right? All these fellas grow up, they got iron overload, big liver, big spleen, big heart. How to treat them? Still, we try to treat them, not because you want to save their life, but they will not be able to grow up to be completely normal because they have done so much damage already to their organs from all the iron overload. Right? And of course, they're chronically anemic. You know, when we do transfusion, right? Dekat Malaysia, when we transfuse, we never transfuse to 14. You're supposed to transfuse a patient to hemoglobin 14. Dekat Malaysia sampai 10, 11 cukup lah balik. How to transfuse to 14? Bagi berapa? 6 units, 6 units of blood lah. Darah kekurangan ya. So bagi 2 unit sajalah. Macam mana bagi 6 unit? So we undertreat them, they don't grow up normally, and then by the time they come for gene therapy, usually they lost something lah. So in a sense, it's correct that they don't become 100% cured in that sense because we treat them a bit later. Pertanyaan kedua aku tak ingat lah. Yeah. Okay, so there is a new treatment now for that. There's a new gene therapy for that. That one, unlike for SMA or for thalassemia, it's not 100% cure. Okay, it's not 100% cure. In fact, I wouldn't even say the response rate is that fantastic, which is why I didn't want to push for it. There are some technical complications, right? The gene, the mutated gene in DMD, Duchenne muscular dystrophy DMD, yeah, is a gene called dystrophin gene. Dystrophin is a big, huge DNA, very big gene. So it's not possible to put that gene into the virus. In this case, AAV virus, adeno-associated virus. So what they have to do is they truncate the gene. They make a smaller copy of the gene, a microdystrophin if you like, and then insert it into the virus, and then inject the virus. So far, the result, honestly, is not that fantastic. Not like SMA. SMA is just fantastic. Cure. Thalassemia, cure. Especially for hemoglobin E. E beta naught, E beta hybrid disease. Homozygous beta naught, the cure rate is only about 85%, not 100%. But for hybrid disease, HBE beta naught is 100% cure rate. So again, it varies by the type of genotype and so on and so forth. For DMD, unfortunately, the result is not so fantastic yet. So many of us believe that the newer version, the new generation of the DMD gene therapy will be better. So we are all waiting lah. Lagipun DMD pun bukan urgent kan. Patient boleh tahan lagi kan. So, but anyway, we work on it. Yeah, we work on it. If I can find it, I can get it. I'll come back and talk to you. Anybody else?
Ya, ada pertanyaan lainnya, silakan di Zoom ada? Di Zoom nggak ada? Ya, Dr. Amira.
Okay, thank you, Dr. Rahmi. Okay, Dr. Lim, thank you. Finally, finally you came here. My first question is about, you said that all the patient that you have treated is cured with the gene therapy. Okay. Is there any side effect of the intervention that you give to the patients? No side effects at all? That's the first question. Is about the cost. You mentioned that the cost is $1 million, but you give the patient, like Dr. Rahmi patient, is free. So how come? So how come? And if I have a patient with maybe like thalassemia, and if I ask the parents if they agree to the gene therapy, maybe. So what are the prerequisite, or what's the patient, or we should do before the patient had the gene therapy? I think that's.
Yep. Question as always from experienced people who are dealing with real problem day to day. First question. The therapy works very well so far for many diseases, even though not necessarily 100% like DMD. But good treatment always comes with side effects. There is no such thing as a good treatment that has got no side effects. Start with SMA. The most feared side effect of SMA is something called acute liver failure, right? The AAV is a virus. Your body will mount an immune response to the virus. And therefore, you can end up with liver toxicity. So far, in the whole world, 2% have died because of liver toxicity. Okay? That has happened. Death has happened, not just having side effects. You actually die from side effects. Now, how do we prevent it? The standard way to prevent it, of course, is to give the patient steroid. Baby Alona is on steroids. So we give them steroid to try to damp down the immune system, and therefore, hopefully, he will not mount a strong immune reaction. But by damping down the immune system in a sick baby with potential for aspiration from respiratory and so she ends up with infection. So it's always like there's a balance you got to strike, because we give her steroid, we're suppressing her immune system, and he's got other risk factor for respiratory infection, and now she ends up with pneumonia in ICU. Second thing we do for baby Arona was that we were very scared to cause an immune reaction. So we decided not to give intravenous. We give intrathecal. So as you know, the CNS is immune privileged. Or at least it will take some time for the AAV virus in the intrathecal, in the CNS space, to get out of the blood-brain barrier into the circulations. Whereas if you give intravenous, the virus goes straight to the liver. Right? Intravenous, first port of call, liver. And the third thing, of course, is that because we give intrathecal, we don't have to wait for the drug, for the AAV to go to the liver, get out of the liver, cross the blood-brain barrier into the CNS. We can use 10 times lower the dose. So the dose we give baby Alona is actually 1/10 of the intravenous dose. So through all that, we hope that to minimize the risk of liver toxicity. Baby Alona has got no raised liver enzymes. Most babies given intravenous will have raised liver enzymes. In fact, most of them will have some raised, some have very high rise of there is acute liver toxicity. Baby Alona case so far, liver nothing. In fact, we already start tapering off the steroid, start reducing the steroid because she's got infection. Second question, the cost. All these gene therapies that we are offering to Dr. Rumah Sakit Dr. Jamil, to all the good doctors here, we are not offering you the original gene therapy. The SMA gene therapy that baby Alona has is not the one from Novartis. I have no money to pay Novartis 2.1 million. Okay? So as some of you will know, no drugs are ever exclusive. Take AV virus. And you know viral vaccine, kan? COVID-19 vaccine tu? Ada berapa kilang buat? Ada AstraZeneca, ada J&J dari US, ada CanSino dari China, ada satu Barat from India, I think satu lagi dari Russia. So many companies can use the same technology and produce the same thing. Right? I mean, ADV virus for COVID-19 vaccine ada sudah 5 syarikat dah seluruh dunia. There are other companies doing the same SMA gene therapy selain daripada Novartis. Okay? So we go and talk to them. And they say, okay, they are running clinical trial. So I say, I invited you to come to Southeast Asia clinical trial. They say, no, but they will provide us the therapy. In return, we need to share the data with them. So they want the data. The more patients are treated, the better the results, the better it is for them, right? as a company, they are looking to the future. That see, I have a treatment that works like Novartis, and I have treated many babies all over in Southeast Asia. Of course, they cannot go to Europe and US. They cannot, because they will be sued by Novartis for patent and all this thing. But they got this power level, no problem. But that's how they give it to us free. The third question is on thalassemia. So thalassemia, again, exactly the same thing. Your patient will get the thalassemia gene therapy free, like in Malaysia. The first Malaysians are going next month. I think about July 24th. The first 2 Malaysians will go to China, Nanning, to receive the gene therapy next month. My suggestion to you is that if you have patient with thalassemia, don't do it here in Padang. Because gene therapy for thalassemia requires a marrow transplant. It's not like SMA. SMA, I just cucuk intrathecal saja habis. Easy. For this, you have to do a marrow transplant. So you need to go to a centers with experience in doing marrow transplant. The centers in Guangxi, they do thousands. They do thousands and thousands of transplants. Remember, they eliminated thalassemia. They do so many over the last 10 years. So even hematologists dekat Malaysia yang ada experience buat transplant, tapi tak pernah buat gene therapy. They felt, you first few cases go, you go and do it there. Then we go there and learn. Right? After that, then transfer the thing back, mulakan dekat Malaysia. I would suggest we do the same thing. Then the first 1 or 2 patients, let them go. Then they come back. Hey, sudah cure. That patient become your ambassador. He then go and tell other patients, hey, hello, no more transfusion, yeah? Wow. Well, that feeling is different, yeah? So I would suggest we do that. Then the subsequent patient, we're going to do a transplant dekat sini. If possible, we go to, Dr. Dina in Harkit or Dr. Eddie in Chichi. I don't think we do transplant here. Can we do transplant here?
No.
So we probably have to send the patient to Jakarta to do the marrow transplant.
Yes,
Yeah. So that was really this. So the preparation, how to prepare the patient, typically most important is iron overload. So we need an MRI. We need to look at MRI for liver, MRI for cardiac, and then we treat the patient intensively. You transfuse them. Never allow the hemoglobin to drop below 10. And you give them triple iron chelation. 2 oral, 1 subcutaneous. And then you just bring the ferritin down. Once they are okay, then go.
So you haven't performed the gene therapy for thalassemia patients?
Dekat Malaysia. Semua dekat China. Dekat Nanning saja.
Okay.
We also don't want to do it because marrow transplant, yeah?
Yeah.
All the side effects from gene therapy for thalassemia berasal daripada marrow transplant or berasal daripada myeloablation. They use a myeloablation, they use busulfan as a myeloablation. And busulfan is very toxic. It just wipe out the marrow. So the side effects are mostly from pancytopenia.
So from all the gene therapy that you have mentioned in your presentations, so which disease that have you done? Is it all SMDMD or SMA? That's
For we have done for almost all of them.
Oh, almost. But you said
Not
you haven't
me
performed.
personally.
Oh yeah, you did your team.
Your patient will not be the first one. Yeah.
Yeah.
Many patients already have done it. Already had the treatment. Now we offer it to Indonesia. Yeah.
Now, by your team, how many?
I'm only a consultant.
Oh.
I don't do the treatment. The treatment is always done, like say for hemophilia or thalassemia, is done by hematologists. I cannot do it.
Oh.
I'm not qualified to conduct a marrow transplant. No.
Oh.
Remember, I'm not a hematologist. I don't treat patients. I only work together with the hematologist or with the oncologist in doing the treatment. I've got one old man just now with bladder cancer for bladder installation to do the oncolytic virus therapy. The treatment is given by a urologist, not by me. I cannot treat a urology patients. I only work on gene therapy. I know a lot about gene therapy. So I advise the doctor, do this, don't do that. Prepare the patient like that. And They're happy to have someone guide them, hold their hand. But to actually do the treatment, bukanlah saya, because I'm not urologist, I'm not hematologist, I'm not oncologist. Aku tak mungkin to be all specialist to all thing, yeah. No, I don't do it.
Okay.
You are doing it, okay, not me. But I will guide you, I'll help you.
Okay.
Yeah.
Thank you, Dr. Lim.
Thank you Dr. Amira dan Dr. Lim. Ada pertanyaan lagi? Dr. Tiara mau nanya? Ya, Dr. Tiara silakan.
Dr. Lim, thank you for your great presentation. I interested because I'm in allergy and immunology division. I interested in your experience in CART in gene therapy in lupus patient. Do you have any experience in lupus patient, and who will be the best candidate for receiving this therapy, and how long does the therapy will be a successfully remission in lupus? Thank you, Dr. Lim.
So I'm glad to meet another immunologist, okay? Because I used to be a nephrologist. So we deal with organ transplant, we deal with SLE, lupus nephritis. So we share the same feeling, yeah. This is one of the more amazing things I've seen. Remember, I've treated a lot of lupus patients myself in the past. So for the first time, we have a new treatment for people with lupus. In my case, lupus nephritis. In fact, all the patients treated so far all have lupus nephritis because it's one of the most serious complications of SLE. Yeah. They had steroid, of course. They had MMF. They have rituximab. They have everything. All the B cells directed therapies that we currently use in SLE, right? So they have so-called refractory lupus. They are basically waiting to go on to dialysis lah. The organ is going to fail. So the first 5 patients were treated in Germany using CD19 CAR-T, chimeric antigen receptor T cells. You read the paper? Published in Nature Medicine? I'll send you the papers. It's amazing papers. So they treated 5 patients with lupus, basically waiting to lose their organ. Kidney failure, dialysis. All 5 patients recovered. And the most amazing part was, not only that they recovered, all 5 patients goes off steroid. And they've been off steroid for 2 years now. I mean, you talk to nephrologists or you talk to rheumatologists, if I give you, hit you hard enough with enough immunosuppressive, I can suppress your disease. The problem is that the moment I stop the treatment, your disease is going to come back. And you get very toxic effect from the steroid. In this case, it's a one-time therapy. One time saja. Satu kali infuse, habis. 2 years later, the patient still in remission. The patient still not on steroid. So the trial have started. The first 5 patients were treated as a case report, not case series. They've started a trial now in the US. There's a trial now going on in China. So we are offered this therapy. You got really nasty lupus, you let me know, okay? I'll try to put your patient on, but I don't promise because it's very competitive. A lot of people want to put their patient on. Yeah. So you see a lot of lupus.
Yes, we have many lupus patients in M. Jamil and several patients with refractory lupus nephritis. So maybe we can talk more about the patient.
Yep. So selain daripada lupus, actually the other one that is we can treat is myositis. Some of the myositis are very hard to treat. So if you have hard to treat myositis, let me know. And then the neurologist treat for generalized myasthenia gravis. You are doing rheumatology, right? Rheumatology, immunology.
Yeah.
So your neurologist colleague will have seen patients with very nasty multiple sclerosis, progressive MS, and then myasthenia gravis. They are all autoimmune disease. And increasingly, we treat them using this technique. We'll be glad to treat the first patient here with you. Then we write out a paper, yeah?
Thank you, Dr. Lim.
Is there still any question? Resident? Belum ada ya? Ya. Dr. Rizka, please.
Hello, doctor. Thank you for the lecture, a good lecture. I'm Rizka. I'd like to ask some question. Is there any some preparation that we have to done for the baby before get a gen examination shot, just like before SMA gen shot? For example, the baby have to the body weight have to up to 5 kilograms or like other, or the baby can get a gen shot at any age and any condition, just like that. Thank you, doctor.
So the most for us for SMA yang paling penting memang adalah keep your patient off the ventilator. Sebelum dia memerlukan ventilator dan feeding tube, then we don't really care about the conditions. And the other one, of course, we look for liver disease. Kalau dia ada penyakit apa, then we don't treat. So we don't treat if they are too gone, too far out. They're already on ventilator, they're on feeding tube. We think that they're not going to recover. Dia tak mungkin sembuh baik. Then it's waste to treat, right? Dan yang kedua adalah dia tak ada penyakit hepatitis B ke, hepatitis C ke, then that's it, we give. And we give secepat mungkin. Secepat mungkin. Like Alona arrived in Malaysia Friday, and then Tuesday we give the treatment. We don't even wait. Because every day the motor neuron are dying. Yeah. So treat them ASAP. Yeah. No special preparation required other than that. Those two.
Beres kah? Oke, lagi?
I'm sorry, sir. How about a patient with leukemia? Is there also no need special preparation to get a gen examination?
Well, Dr. Mira is an expert here, not me, but for ALL, right, childhood acute lymphoblastic leukemia, and then the preparation is more complicated. The preparation, basically, we only treat them when they have relapse. As you know, ALL is a fairly good, easy disease to induce into remission, at least the first time. Most of them will go into remission. And some will stay in remission for a long, long time, especially they got no CNS disease and no other extra. So if we have someone relapse, we'll tell them to go back and do a second round of chemo. Multiple relapse, or they have early relapse within the first year. You know, baru kita induce remission, tak sampai satu tahun sudah relapse. That's bad news. That's bad news. Then we will consider early CAR-T, chimeric antigen receptor T cells. In that case, number one, the first preparation is we often re-induce remission. We don't, by and large, like to give you CAR-T when you have very high blast count. Right? So we try to re-induce remission, or otherwise put you on a bridging therapy to reduce your blast. That's probably the most important preparation. So if your blast count is very high and I give you a CAR-T, CAR-T is very potent. CAR-T will practically just kill off the tumor cells like that. So you can imagine that you have billions of blast leukemic cells circulating, and now I gave you an infusion of CAR-T, and within 2 hours, 3 hours, all the blast cells died. What do you think happened? You end up with a cytokine storm. Right? You heard of cytokine storm? CRS, cytokine release syndrome, is called that. That's a very nasty disease. In the first few patients we treated, they all went with CRS. Some of them go onto ventilator and go into acute renal failure. because we were desperate, the patient was dying, so we treat them very urgent. Now we are smarter, we try not to treat so fast. No, let's control the blast. Let's do disease control. Let's control the sepsis. Then only do CAR-T. Don't rush. All right? Because the patient can die from side effects and not from the disease side. So sepsis, high blast count, or we call them high tumor burden. Don't treat, don't rush to treat. Prepare the patient well, then treat. So we also gained some experience over the years in managing this patient. I hope to be able to treat one for Dr. Kamera one day, okay? She'll be impressed, all right? Get a baby into remission, okay? Who have relapsed multiple times. Very satisfying, okay? Yeah.
Terima kasih Dr. Lim dan Reska. Apakah masih ada pertanyaan dari audiens di ruang Departemen IKA? Kami persilahkan juga kepada Bapak Ibu di Zoom meeting yang hadir secara online. Bila ada pertanyaan kepada Dr. Lim. Ya. Oke. Ya, kita sudah 1,5 jam ya. Quite a long time for special lecture. Okay, maybe we'll take a picture first. Yeah, together. Yeah. Ya, bila tidak ada lagi pertanyaan dari Bapak Ibu di Zoom meeting, mungkin ini bisa kita.
Excuse me, Rami, may I ask a question? Only one question, Rami.
Ya, silahkan, Dokter Riri.
Excuse me. Thank you for your chance for me. I want to ask about the gene therapy for IBD. Maybe you have experience for gene therapy for IBD, like a Crohn's disease or colitis ulcerative. And so, how about the Gosser? Gosser, have you gene therapy experience in Himalaya? Thank you.
Yeah, Dr. Lim, the Dr. Iris, the gastroenterologist consultant. Yeah. Yeah, please, Dr. Lim. IBD. Yes, bowel disease.
So, I'm sorry to mengecewakan kamu, Dr. Lilis. Sampai hari ini belum ada gene therapy untuk IBD ya, belum.
Okay, so how about the Gosser? You said that Gosser is include the give therapy, gene therapy. In my division with Dr. Nietzsche, Gosser is very bad about the damage of liver. So what is your experience about the gene therapy in Gosser?
Gosser disease, inborn error of inborn error metabolisms.
Inborn error of metabolism, huh?
Yes,
yeah, of course. Many of them will be liver disease. What do I have now for liver? Well, there is one coming up for a disease called the Wilson disease. The Wilson disease, that can manifest as liver. So if you have anyone with Wilson disease, you let me know.
Yes, there is Wilson disease, but we cannot find in our hospital. We only have a Gosser disease.
Yes, Gosser.
We have actually one for Gaucher disease. If your patient will consider for the gene therapy, you send me the details. I will quickly ask the manufacturer. Is that all right?
Okay. Okay. So you have experience to give a gene therapy for Gosser disease in Malaya?
I have no experience. We haven't done any in Southeast Asia, but the trial is going on in China. I know there's a trial going on in China. I can help you inquire for it.
Okay. Let us ask Dr. Rami Lestari to find you about your email. So maybe with Dr. Nietzsche we can collaborate to connect you to therapy about the Gosser disease. Thank you, sir.
Thank you.
Yeah. Thank you, Dr. Riri. Apakah Bapak Ibu di Zoom meeting masih ada pertanyaan? yang masih ingin didiskusikan dengan Dr. Lim? Bila tidak, mungkin untuk guest lecture-nya kita akhiri dulu ya. Terima kasih banyak atas kehadiran partisipasi dari segenap Bapak Ibu yang berada di ruangan maupun hadir secara online. Semoga ilmu yang di-share oleh Dr. Lim hari ini bisa memberi banyak masukan, manfaat, menambah ilmu pengetahuan kita, memberi manfaat buat pasien maupun pengembangan kolaborasi ke depan. Amin ya rabbal alamin. Terima kasih Dr. Lim untuk kuliahnya yang luar biasa. Mungkin kita akhiri dulu online ininya. Nah, selanjutnya untuk Bapak Ibu di Departemen IK, mungkin kita foto bersama dulu ya, nanti lupa, ini udah berkurang satu persatu, tadi harusnya kita foto di depan, di awal. Foto dulu yuk. Lainnya ditutup aja sih. Iya.
siang hari ini, Zoom ataupun offline. Terima kasih atas kerjasamanya. Semoga apa yang sudah kita dapat bermanfaat untuk pasien-pasien kita. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.